Oh, you got this one, huh? Hello again. I think we are good to start the next session. And the speaker for this session is Dr. Eddie Stenehjem. So he is with Intermountain Healthcare. He's a senior medical director of medical specialties, leading 11 medical specialties for Intermountain Healthcare, including antimicrobial stewardship and infectious disease. Prior to this, he was our medical director of antimicrobial stewardship, overseeing antimicrobial stewardship programs across the 23 hospitals of Intermountain, as well as over 185 outpatient clinics throughout Utah and Idaho. He trained in internal medicine at the University of Colorado and completed his infectious disease fellowship at Emory University in Atlanta and moved to Intermountain in 2012. He founded the telehealth infectious disease program that serves our rural hospitals and hospitals without infectious disease specialists. And his research is focused on improving the quality of infectious disease care delivered to patients, with an emphasis on developing, implementing, measuring, and studying methods of improving antimicrobial stewardship practices across the continuum of care. His current work is focused on improving antimicrobial use in Intermountain's network of 39 urgent care clinics and assessing COVID-19 vaccine effectiveness. He's also served on multiple national committees and has represented Intermountain Healthcare at the United Nations, the CDC, and the White House. So we felt that there was no better speaker to give us this talk, since antimicrobial stewardship is his field. So could we please welcome Dr. Eddie Stenehjem.
I think I'm good. So it's been probably 2 years since I've spoken in front of a live audience. So this is really a unique opportunity for me the past couple of years. And I've done a lot of speaking engagements on COVID, and so it's really nice to be able to speak on stewardship and have a live audience. So thank you for being here. I'm taking off my mask. I'm fully vaccinated, as I would hope that you'd think I would be. All right, I have no disclosures. Purpose and outcomes, I hope, will be very clear by the end of this. So this is your one slide on the why of antibiotic stewardship. Okay, so most stewardship talks focus on the why. I think we know the why. Okay, so I'm not going to belabor this point. We know that there's rising resistance, and what we're seeing with the COVID pandemic is accelerating this. So if we look in the hospital and we look at ESBLs and multi-drug resistant gram-negatives, this is becoming more of an issue. Overuse of antibiotics is a patient safety issue, and that's the way we frame this. We think about C. diff as the quintessential topic of patient safety, but we also need to think about all of those unattended symptoms that patients have from antibiotics, so the augmentin and the diarrhea, and all of these things that don't come to our attention, but is a huge quality of life factor. There's very little antibiotic development, and you may push back and say, oh, what about Zerbaxa? What about Abicaz? What about Dalbavancin? All these things. These are all antibiotics targeting multi-drug resistant pathogens. They're primarily all intravenous, and they almost all cost about $3,000 a regimen. Okay, so these are not the antibiotics that we're going to use in the outpatient setting on a routine basis. There isn't development of those drugs. So we have what we have for the time being. There's increasing regulatory pressure. Joint Commission, CMS now all require antibiotic stewardship programs for their guidelines, whether it be inpatient and outpatient. And we're now being pushed more and more to show what we're doing to target these things. And there's now obviously a shift to value-based care models. Okay, and so as we're looking as payers moving from a fee-for-service to value, this is where stewardship comes in. And so if we're using antibiotics and we're developing resistance, more resistance costs more money and has worse outcomes. Okay, so we really need to be focused on this, and it's the right thing to do for our patients. So that's it. That's your one why slide, and we're going to move on from there. So just to kind of highlight what we've done within stewardship. In 2012, when I joined, we had 3 stewardship PharmDs. Actually, McCady Hospital with Dustin Waters was one of the first antibiotic stewardship programs in Intermountain Healthcare, and Dustin has led that program fiercely for the past 12 years and has just done an amazing job. At that time, we had an enterprise committee, and we had lots of potential. Now in 2021, all hospitals are covered by a Joint Commission accredited stewardship program. We have 13 stewardship pharmacists. We have an ID Tele stewardship program that is a beacon of best practice for the nation. We have a centrally organized structure. We have dedicated leadership. We have national recognition. We've been highlighted at the White House, the UN, the CDC, and we have a robust research platform. So we have come in so far in the past 10 years in improving antibiotic use that people look to us, look to Utah, in how to do this. And so we're really, really proud of that. So I'm going to be walking you through a program we did in urgent care and kind of showing you how we did that and some of the results. Part of it was funded through a CDC Shepherd contract and with also some collaborators at the U. So when we think about stewardship now, in 2021 and 2022, we have to realize that healthcare has changed. We know that people are now seeking care outside of our traditional bricks and mortar primary care and hospitals. We now have telehealth. Anyone could call into Connect Care and have an appointment literally in 15 minutes out in the bathroom if you want, and we've had those visits. We have 39 urgent care clinics that we're going to talk about today. We have specialty clinics. 10% of outpatient antibiotic use are prescribed by dentists, okay? Never been a target before for stewardship. We have to realize that this is changing and that hospitals aren't all the same. We've got large academic hospitals, we've got large community hospitals, we've got small community hospitals, we have critical access hospitals. And turns out they all prescribe antibiotics the same in terms of the rate of antibiotic use, and we have to address all of them. Not to mention retail pharmacies. You can now walk into a pharmacy and say, I have urinary tract infection symptoms, and leave with an antibiotic. You can go in and get strep tested and leave with an antibiotic without a physician. Okay, these need to be targets of stewardship. And traditionally, what we've targeted for stewardships are the flagship academic hospitals that do research and the primary care clinics. That has been the target of stewardship for the past 15 years. Okay? And we need to change that. We need to change that to include wherever antibiotics are prescribed. And so urgent cares, dentists, specialty clinics, small critical access hospitals that need to be covered by a tele-stewardship program, retail pharmacies. I think it's great to give patients that access in pharmacies as long as they're appropriately trained in diagnosing the infection. Okay? Obviously, everybody knows here that UTIs are the bane of a steward's existence, right? Is it infection? Is it colonization? Do they have positive UA? You know, all the questions you've been asked by a stewardship pharmacist. We need to make sure those things are embedded into all of these areas where you can get antibiotics. So our charge is in healthcare systems and in individual clinics, is structuring stewardship programs to improve patient care and population health in all health environments. Okay? And we need to kind of break out of these silos of, oh, this is a primary care clinic issue or this is a hospital issue. We have to structure our programs to reach all of these sites where antibiotics are prescribed. The good thing we have going for us is that the CDC has put together core elements of stewardship. And I am biased on these elements. I helped create these elements, so I'm going to just, acknowledge that. But this is the framework in which we think about stewardship, regardless if you're in a hospital, a clinic, a retail pharmacy, or home care. Okay, so this gives us the common language to structure the way we think about improving antibiotics, and it comes with leadership commitment, somebody who says this is going to be a priority for us. It comes with accountability. Who's on the hook for antibiotic prescribing appropriateness and who's driving this? It comes with pharmacy expertise. Our pharmacists do the lion's share of this work, and they are incredible advocates for us. What's the action? What are you going to do to improve antibiotic use? How do we track this? And that's a big question nationally. How do we track antibiotic prescribing in CVS? How do we do it in Walgreens? How do we do it in animal clinics? And so those are all really common questions that we're asking. How do we report this? How do we educate? So these are the common framework that we use to set up these programs across Intermountain Healthcare and really across healthcare in general. So what is the challenge of non-traditional stewardship settings? There's a number of them, and we've been working in this area for quite some time. One is it hasn't been a focus for stewardship. And so we go and we talk to dentists, and they haven't heard this narrative. They haven't heard the why behind this. They haven't seen those terrible C. diff cases that result in colectomy that Petronella and I deal with in the hospital. And so it's not on their radar. Many times there isn't a pharmacist in that clinic or in that service line to help intervene. Many times these are transactional visits. Think urgent care. I'm going to come in, I'm going to see you, I'm never going to see you again. Okay, and so you don't have that relationship with the patient to build upon. We have very little data on success. There's incredible data challenges, and many times it's not a priority for the clinician in that role. Okay, so we have to address all of these challenges as we move forward in implementing stewardship in these areas. Okay, we copy that. We're going to shift gears and now talk about how we met those challenges in urgent care. Okay, so urgent care is going to be really our case series, a case point here of how we actually did this. And so here's some baseline information about urgent care. Urgent care prior to the pandemic, so prior to 2020, early 2020, was the fastest growing site of outpatient care delivery in the US, with the number of encounters increasing by 50% or more in the past 5 years. And so this is a graph on the bottom there that shows the number of urgent care sites across the US, and you can see it's gone from about 6,000 in 2014, and now in 2021 it's over 10,000 urgent care sites. Many of these are privately owned, but many of them are also within healthcare networks. So why have they grown? Let me introduce you to my wife, Karen. She's an internist at the VA, and that's our daughter, Josie. It was Friday. It was about 7 p.m. My wife's 22 weeks pregnant with our second child. Josie is full snot, and it's January, okay? Flu is circulating. And so our question was, oh my gosh, does Josie have flu, and do we need to treat my wife with Tamiflu because she's pregnant? So we left our house at 7 o'clock. We went to an Intermountain urgent care that was 9 minutes away. We checked in. We saw a physician within about 10 minutes. We got a Cepheid test for flu and RSV. They said, great, thanks. We'll call you in 25 minutes. We went home. We got home at 7:40. At 7:50, the urgent care called and says, you have RSV and Josie. We said, great, nothing for us to do. It was that convenient, and the care that we received was excellent. We received a diagnosis of RSV in our 2-year-old child, and that implicated the fact that we didn't have to treat Karen with Tamiflu. Okay, so urgent cares are an amazing resource for that type of care. And so that's why they're becoming more popular, and they're so much cheaper than going to the emergency department. They're many times 1/10 the cost of going to the ED. So it makes sense for us to use urgent cares. However, the challenge is that urgent cares are the most common site of inappropriate antibiotic prescribing. And so in multiple studies now, when we look at diagnosis that should not get antibiotics, think bronchitis, think cough, acute respiratory infections, those ICD-10 codes that shouldn't get antibiotics, urgent care typically is the highest prescriber of antibiotics in those settings. In this study, it was 45% compared to 17% in medical offices. So now you've got this increasingly common care delivery site with really poor prescribing. It's making a huge opportunity for us to really focus on it. So Intermountain Healthcare, when we look at ourselves, we had 39 urgent care clinics. We had 32 Instacare clinics, see people of all ages, 6 Kids Cares, which sees 18 and under, and 1 Connect Care, which is our just virtual platform. These are predominantly staffed by physicians. About 90% of our caregivers here are physicians, and mostly are family practice. And these are strategically located across our state. 90% of Utah residents live within a 10-minute drive of an urgent care. 90%. So clearly these are located in areas where there are population densities to serve them. Up until 2019, there's no formal stewardship structure. And when we looked at our data, over 50% of ambulatory antibiotics came from this urgent care network. And that's saying a lot because we've got over 185 clinics. Okay, so this clearly had to be a target for us in terms of improving antibiotic prescribing. So the next question said, well, is it a problem? You know, do we have a situation where we actually need to address this? Well, when we looked at the data and we looked at urgent care encounters, we saw that about 41% of the encounters were respiratory related. So these are the coughs, the colds, the sinusitis, the otitis, the pharyngitis. 40% were were for these types of encounters. And antibiotics were being prescribed very, very often, with 34% of all encounters at an urgent care leaving with an antibiotic. Okay, so clearly there's an opportunity here, and clearly we need to focus on the respiratory variety. So we published this paper in 2019 that looked at antibiotic prescribing variability for respiratory encounters. Okay, so one of the biggest pushbacks I always get is coding. Like, oh, I don't code this as a bronchitis, I code this as a sinusitis. We've developed a metric that is an all respiratory prescribing metric. I don't care how you code it. You can code it in pneumonia, you can code it otitis media, you can code it a bronchitis, a cough, I don't care, it's all respiratory. And so that's what fits into that bucket. So it's a big bucket of encounters, and it gets away from this argument about how you code things. Because what we see in the data is we have providers that are sinusitis coders, and then we have providers that are URI coders, okay? And they're the same patients. They're the same patients in urgent care, and so it's just a matter of how you interpret the diagnostic criteria. So we call this just all respiratory prescribing. On the left, you see the prescribing rate for respiratory encounters for the clinics. So the open triangles are the Instacare clinics, the stars are the kids care, and that square one is Connect Care. And we see that we have a clinic that's prescribing 81% of the time for respiratory encounters, and then we've got other clinics that's prescribing 30% of the time for respiratory encounters. These are the same patients. When we look at the patient demographics across our urgent care settings, there's slight differences, but not enough to account for what you're seeing. But the true variability comes at the provider level. And so on the right, you see the graph. Every small dot is an individual provider. So it's about 40 clinicians you're seeing there. And on the right, you've got a clinician who's given antibiotics 91% of the time for respiratory encounters. That is over 2,000 encounters that clinician saw for this data. On the left, you got clinicians that are given antibiotics 10 to 15% of the time for respiratory encounters with the same amount of encounters. Okay, and then you've got everyone else in between. So clearly not everybody on this graph can be correct. I think we all can agree upon that. That variability of 10% prescribing to 90% of prescribing is just way too much, and that's what we set out to really focus on. So we were going to take our CDC core elements and adapt them to urgent care. That hadn't been done before, and we wanted to know, can we do that, and can we get results in urgent care just like we've done in primary care? So the first thing we did is to set out was to develop partnership. I couldn't, as an infectious disease professional, walk into an urgent care and say, you need to do this better. Let me show you how. I mean, come on. Like, I see patients in the hospital with Staph aureus bacteremia. I am not an urgent care doc. But Tony Wallen, who's our senior medical director of urgent care, is. And so the first step we went to is we said, Tony, here's the data. What do you think about doing an intervention system-wide for this? And he said, absolutely 100%, I'm fully committed. If he had said no, we would have said, all right, we're done. Here's a cool paper we wrote, and then we couldn't do it. Because we had to have the commitment of our senior leader to say that this is going to be a priority for urgent care. And you'll see through the next slides what that meant for us. Kim, on the right, is our implementation scientist. What we've learned through the years is that unless you partner with somebody that has any inkling of how to implement, you're not going to be successful as many times as you'd like. And so Kim is an implementation scientist, and she walked us through this, and you're going to see kind of how that changed our approach. So here's your prerequisite research slide. It was a pre-post design. It was 24 months. Pre-intervention was the 12 months before. The intervention was for 12 months. It ended in June 2020. And it was all Instacare clinics across the system. We weren't interested in a pilot. We knew this was the right thing to do, so we were just going to go across the system. Here's our timeline, and really I just want to highlight is the fact that we spent a year working on developing our intervention. Okay, we spent a ton of time really thinking about how we were going to do this and developing our tools to improve antibiotic prescribing. And that was probably our most important time spent. So the first thing we did is we went out and we talked to people. We went and we interviewed patients, and we interviewed clinicians, we interviewed the MAs, we interviewed the nurses, and we tried to understand why people were coming to urgent care and what their expectations were. The patients said almost unanimously, 12 out of 13 said, I have no expectation of an antibiotic. I'm coming here to be assessed by a highly valued, highly trained professional in the symptoms I have and to get some kind of medication to make me feel better. 12 out of 13 said that. When we go to the clinicians, we said, why are patients coming for respiratory visits? What do you think they said? They're coming for antibiotics. Almost all of them said that. They're coming for antibiotics. And then when we pushed them, we said, well, can you do stewardship? They rattle off a very significant list of why it's really hard and how it wasn't aligned with their incentives. So if somebody comes in with a respiratory visit, in general, some data says it's a shorter visit. If it's a shorter visit, you can see more patients in a busy urgent care clinic. If you're paid on RVUs or transactional billing, that means you can see more patients and you can make more money. Okay? If you give an antibiotic, you can prescribe at a higher level. You can bill at a higher level. It's a prescription medicine, so then you can bill at a higher level. If you give an antibiotic, the patients are perceived to leave happier. Okay? Not that they necessarily are, but that potentially could impact patient satisfaction scores, and everybody's happier. If you give an antibiotic, many times there's less patient-clinician conflict. And if I was an urgent care doc, seeing 40 patients in a day, 20 of them having respiratory visits, and I was having this conversation about I'm not going to give you an antibiotic 20 times, that's going to make for a really stressful day. Okay? So I'm not saying that they were wrong. I'm saying that our system was set up to get the results that we were getting. And that was a motivation in some cases, whether it be intentional or not, to prescribe more antibiotics. And so we realized we had to address these things if we hope to be successful. And so then we had a little socialization phase. We went out and took tours. We went to urgent care clinics. We saw the patient flow. We talked to the MAs. We understood how they got checked in, where were opportunities for us to educate, and particularly how can we educate patients without necessarily hitting the physician, hitting the clinician, hitting the APP. How can we get to patients indirectly? And we learned a lot on some of these tours. So we developed 5 categories of stewardship interventions: education of clinicians and patients, EHR tools, benchmarking dashboard, so just transparent data, media, and then organizational alignment. So education for clinicians. We went through and we updated all of our guidelines for common things seen in urgent care. So bronchitis, sinusitis, otitis, pharyngitis. We showed up to urgent care clinician meetings every single month, and we gave presentations on these, and we were there to answer questions. We had a clinical champion that was an urgent care doc that was leading out on this as an urgent care clinician, and he was demonstrating how he did this and how he spoke to patients. We had podcasts and blog posts. This is Mark Harrison, our CEO president, and it was important for us to have this conversation with Mark and put it out to our clinicians so our clinicians saw that our leaders were behind this, that our leaders were engaged with this, and they thought this was important as well. We developed clinic materials, and we had a very accessible website for our clinicians to use. Then we also developed patient education materials. And so watchful waiting and a delayed prescription was one of our interventions. And then also these symptomatic therapies checklists was also part of our intervention. But the unique thing is that we had patients develop these tools with us. So we went to patients and said, hey, this is our idea of an education material. What do you think would be valuable to you? And they're the ones that directed to this. And so I can't take credit for creating these. Our patients created these. And I thought a symptomatic therapies checklist was just something you had to do, and it was on all the guidelines, and I would say, fine. But when we talked to patients, we said, what do you think about this? And he said, well, it'd be really impactful if the clinician filled that out with me. And we said, tell us more about that. And so they said, well, if a clinician went through and said, hey, I want you to take this, this, and this for your sore throat, and I want you to take this and this for your cough, and this for your fever, that to me is somebody creating a valuable treatment algorithm for me. That's not a generic, here, go take this. But this is something that is created with the physician, with the APP and me, and I see value in this. And we asked, is this as good as an antibiotic? They said, oh, absolutely. It's better than that because it was created for me. And that's why our symptomatic therapies checklist is just left open for the clinician to go through and check off what they think that patient should take for their symptoms. We also developed electronic health tools, pre-templated notes for workflow enhancement, especially for these really fast-paced urgent cares. We developed a delayed prescription note that was in our orders or in our electronic health record, so they can click it and they didn't have to go through and put all the comments in, and then we can actually measure delayed prescriptions. And then we did something that was kind of annoying. I'm going to completely agree. We had an azithromycin justification alert. There's one instance where you should use azithromycin for a URI, and that's in a child who's got a penicillin allergy, who's got pharyngitis. Okay, that's about it. And so if you wrote an order for azithromycin for somebody with a respiratory encounter, you'd get this really annoying flag that said, "Really? Why do you want to do that?" And then they would have to go in and click why. And then if there wasn't one of those good reasons, then they'd have to justify it. And then that justification would go in the EHR. And so like, this is why I did azithromycin. And I agree that it's kind of absurd, but it works really well. So moving on. Provider benchmarking dashboard. Intermountain has this legacy of transparent data. And so we created a dashboard that is fully accessible to anybody with Intermountain Healthcare that shows antibiotic prescribing at the system level, at the clinic level, at the provider level. So you can go in and see what your antibiotic prescribing is compared to your peers, compared to other clinics, compared to the system. And you can then go and talk to people that have better prescribing than you. You know, we didn't want to make people hide behind their data. We wanted this to be fully open. And that's what they did. And so they would see in their clinic, oh man, I prescribe antibiotics 3 times more than my peers. Let me go talk to my clinic peers and understand how they're talking to patients about this. And this was fully available across the system, and we had a number of ways to make sure that people were going and engaging with this data to see what their status was. And then behind the data, we included all the methods of how we generated the data. We did not hide behind the methods of how we did this. And so we were very upfront. We put our methods on the website. We sent people the Excel file that had 1,400 ICD-10 codes that are all coded, and we said, pick it apart. Where do you have questions? Let's get this right. And we engaged them in the development of the measure. And so that when they saw their measure, they actually believed it and trusted it, and knew that they could actually change their measure over time. And so this is just an example. This is transparency with data and methods. This is our website, and there's a question that says, can you provide the specific respiratory ICD-10 codes in the respective designation? And we said, sure, and we made a link, and we said, here, email me if you have any questions. And so we did this for all the questions that came up, and we just made it readily available and said, take a look under the hood, make this better for us. And then media. One of the things that the clinicians told us was that I want that patient to be aware of this initiative before they get in my clinic. I don't want to be the first one that's telling them about our commitment to antibiotic prescribing and appropriateness. They wanted to make sure that they knew about it before they stepped foot into that exam room. And so we created these really nice clinic wraps and circles and stickers, and they have all these names for it. There's one that's a dangling thing that's got my picture on it. So they're just plastered all over urgent care. And the reason that they did that is that over 50% of urgent care visits are for infections or infectious related. And so that is their bulk of business. And so they wanted to make sure that they were driving this point home with their patients. And many of the clinics just took this upon themselves and handed the patient, a symptomatic therapies checklist, an informational brochure when they got checked in, and so they could read it while they waited for the clinician. And so it really allowed the patient to understand, like, oh, this physician's going to talk to me about this. This APP is going to talk to me about this. And so then that conversation that the physician and APP had was easier. And then organizational alignment. This was not intended as part of the study, but this was something that urgent care leadership realized they had to really focus on. And instead of paying our urgent care physicians and APPs on a transactional basis per amount of visits seen, they said, we are now going to compensate you on shifts. Okay, so we're going to say X amount of shifts equals this. And part of that compensation was meeting quality indicators, quality benchmarks that they had agreed upon as a service line. And so what this did is it took all of those barriers about RVU compensation and seeing patients faster and patient satisfaction and changed the tone completely and said, okay, I'm going to be paid on a shift-based methodology, and I don't have to worry about RVUs. I need to worry about taking care of the patients correctly. And one of the quality measures, they only had two, one of the quality measures was our respiratory antibiotic prescribing rate. And the clinicians wanted that because they could impact that. Their actions could directly impact their quality scores, which is what they wanted to do. And this was a system-wide, no exceptions opportunity for us. We had lots of different outcomes. Our first outcome was this respiratory prescribing rate, but we looked at a whole bunch of other stuff. First-line therapy, tier 3 prescribing, that's for bronchitis, et cetera, delayed prescribing use, azithromycin use, and then also balancing measures. We wanted to make sure that we weren't harming our patients when we were doing this, so we looked at 14-day hospitalizations after respiratory visits, 14-day ED visits, patient satisfaction scores, and the like. And so we wanted to make sure that we were making sure our patients were safe. And then we set a goal. Our goal was 50%. And so if you remember that initial slide that looked at respiratory prescribing across urgent care, our median was 50%. So we had 50% of people prescribing above 50% and 50% of people prescribing below 50%. And our goal was to get everybody to that median, 50% or below. And that's what our target was set at. So the results, total urgent care visits pre and post looked about the same. We had over 200,000 respiratory encounters in the 12 months pre and then the 12 months post. And this is our results. So we started, like I said, at a baseline of 50% prescribing. We initiated this program in July 2019, and then we've had this steady decrease in antibiotic prescribing, and now we've decreased respiratory antibiotic prescribing by 50% across the entire system. So that sounds great, but what does that translate into antibiotics saved? Well, that's over 200,000 respiratory visits, and so that's over 31,000 prescriptions avoided. That's over 250,000 days of antibiotics prescribed if you consider most of these are a 5 to 7 day script. Okay, so and that's just in 1 year. And as you take that data out, this past month in September, we were still at 23%. Okay, so we have fully changed the culture of antibiotic prescribing in urgent care through this intervention. And so we've maintained this now for 12 months post the end of the intervention, which really shows this sustainability in our intervention. Like I said, here you go, 23% is our last data point that we have. The other thing that we should highlight is that this wasn't driven by 3 or 4 clinics that were high prescribers. On the left, you have all the different urgent care clinics. The green is the pre, the orange is the post, and that's your respiratory prescribing. Every single clinic in our system improved their antibiotic prescribing, all 39. And on the right, each dot there is a prescriber, is a clinician. And we looked at the change post versus pre. And so if you went to the left, if you were in green, you reduced your prescribing rate in the intervention period compared to the pre-intervention. If you're in orange, you increased your prescribing during the intervention. 95% of our clinicians decreased their prescribing, some of them on the tune of 20 to 30%. Okay, and so this was an intervention that penetrated all clinics and essentially all providers. And the ones that increased prescribing, you'd ask, like, how did that happen? They're ones that were low to begin with. They were at 20% to begin with, and they went up to 25%, but they were well at goal. And so we really had this penetrance of our intervention across the system. First-line antibiotic therapy for sinusitis, otitis, and pharyngitis went from 70% to 74%. Our goal is 80% for that to account for allergies and also account for people that have recurrent visits that need different antibiotics. So we're on our way there. Antibiotic prescriptions in people that have encounters that shouldn't get them, so bronchitis, URI, and cough, we were at a baseline of 20% of antibiotic prescribing. We went down to 8% during the intervention. Azithromycin use wasn't high to begin with. It was 9.7%, and it came down to 3.3%. Okay, so we certainly made progress there, compliments of that very annoying alert. And then delayed prescriptions. We now are able to track delayed prescriptions with an order sentence. I'm a fan of delayed prescriptions in urgent care. Okay, these are visits that they don't want to come back. They don't have the ability to call back if they're not feeling well. So we encouraged delayed prescriptions for sinusitis, particularly in adults. And we now have about 20% of people that are seen for sinusitis or otitis getting a delayed prescription. And that prescription actually counts in the respiratory antibiotic prescribing metric. So we're actually lower than what we had thought. And when you look at claims data within Select Health, only 50% of people that got a delayed prescription filled it, compared to 90% of people that got a regular prescription. So these things, are interventions that actually improve care. This is just our modeling, showed that the odds ratio for an antibiotic prescription now is 0.53 with the intervention. So showed essentially halving of the odds of getting an antibiotic. First line prescription, the odds ratio is 1.24, so increasing the likelihood of getting a first line antibiotic prescription. And tier 3 conditions went down to with an odds ratio of 0.3. This is important. This is your balancing measures. These are things to show that, hey, we were safe, okay? Hospitalizations for respiratory encounters, 0.2 in the pre, 0.3 in the intervention. So not significantly changed. And the patient satisfaction score went from 4.38 to 4.28. We knew we were going to get a slight reduction. And when you look at the data in patient satisfaction scores in the baseline, there is a difference. Okay, I'm not going to hide behind that. And so as we increased the number of encounters that didn't get an antibiotic, we therefore reduced the patient satisfaction score by 0.1. But that was okay, because our leaders knew that that was going to be a complication of this, and this is what we expected, and it's not a very significant decrease in our patient satisfaction scores. So our key takeaways. One is that urgent care antibiotic optimization in the urgent care setting is feasible. People were telling us, you can't do this, it's not going to be possible. Not only is it feasible, but we had a very significant reduction, and it was safe. We saw no signal that this was by any means harming our patients. Alignment and prioritization is absolutely critical. Interventions like this take time and planning, and we have to focus on the continuum of care in terms of antibiotic stewardship. That has to be a focus of ours, not just inpatient and primary care. And so this is my last slide, and we'll open up for questions or comments. So future directions is really to continue to engage with urgent care to learn what worked and what didn't. This was a full-scale or all-assault approach to improve antibiotic prescribing, and we want to know what worked and what didn't, so then we can take that to other systems, and how can we improve the intervention. And then how do we expand into community-based care settings? How do we take what we did in urgent care and pivot it into primary care, where the number of respiratory encounter visits is much, much less? Okay, it's not the priority necessarily in primary care. And so we have to figure out, how do we effectively move this and make it an effective strategy in family medicine and internal medicine? And then how can we use this model for other clinical scenarios? And so we've already taken this platform that we've developed, and we're now using it to improve sexually transmitted infection screening. So Utah is a pretty low state for screening for HIV and syphilis. And so we've taken this and said, how do we improve that? And we're using the same methodology that we used here to improve sexually transmitted infection testing. And we've seen a 50% increase in HIV testing just in the past 3 months. And so this is a model that's going to work for us within our urgent care setting. That is it. Happy to take any questions regarding this or COVID-related matters, which is usually what I talk about. Yeah.
Trouble, but having practiced allergy immunology for 40 years, it's pretty hard to tell acute bacterial sinusitis from viral sinusitis. Always virus, almost always. It gets diagnosed a lot of times as bacterial sinusitis. But something, this is where I might get in trouble. It's about 3 or 4 years ago at the Academy of Allergy, and I think it's been the standard of care since. There have been multiple studies of moderate and severe asthmatics with acute exacerbations with rhinovirus and better outcomes if they're given azithromycin, thought to be because of its anti-inflammatory effect.
Right. So not going to get in trouble. Totally agree with you. So let's back one step up. The most common diagnosis that leads to an antibiotic in outpatient settings, urgent care or otherwise, is sinusitis. Hands down, especially when you look at adults. It is the driver. And when you look at that, and you actually look into the patient's charts and you say, do you meet the criteria for bacterial sinusitis, acute bacterial sinusitis, so durations, severity, that double worsening, those three, over 90% don't meet that criteria at all. Okay, so putting aside the severe asthmatics and the cystic fibrosis patients, the bronchiectasis patients, which are not common in urgent care, putting those aside, the vast majority of sinusitis can be treated with symptomatic therapies only. And that is where we really utilize this delayed prescription. Okay, people come into urgent care and says, I don't want to come back. I don't want to take another day off work to come in. I get it. That's absolutely right. And so that's where we use these delayed prescriptions to say, okay, I don't think you've got a bacterial sinusitis at all. But in 5 days, if your symptoms are worsening, here's amoxicillin. Okay, go fill it and go ahead and take it. And most people don't take it, only 50%. The patients you're talking about, those are challenging. And the question is does azithromycin do anything from an antibacterial standpoint versus an immunomodulatory standpoint? In the CF literature, I think it's almost all immunomodulatory, COPD, immunomodulatory, based on those studies. So we definitely don't fault you from that standpoint. And azithro is pretty low likelihood of causing C. diff. It definitely has this association with cardiac dysfunction and cardiac death, actually at a higher rate than our COVID vaccines, but we don't need to talk about that. So I think it's, yes, I completely agree.
I don't think it has the contraindication that other macrolide antibiotics have with cardiac.
It has, so the New England Journal article back about 5 years ago did show this association with azithro and cardiac arrhythmias. Not as bad as the previous that you're alluding to. So, yes.
Did you guys look at the patients, seeing if they were, during your intervention period, if they were going to their primary care and then getting prescriptions? Because
yeah.
My office does have urgent care availability, but we're not designated that, so I don't just get hounded with just those patients.
Right.
And of course, as other primary care docs know, the idiots down the street didn't give them that, and so then they come see us. And, I'm curious if you guys looked at that to see if there was an increase in the primary care settings, especially if you looked at it from the Select Health perspective to see if you're, if they were getting it, but from another clinic like I work at.
Yeah, incredibly insightful question. And one of our biggest concerns was exactly that. Go into urgent care, they didn't give me an antibiotic, so I'm going to call my primary care doc and say, hey, Joe Schmo idiot over there didn't give me my Z-Pack, can you call it in? When we look at antibiotic prescribing in internal medicine and family medicine, it didn't go up. Okay, we actually see a decline, likely just from this kind of diffusion of the intervention into those settings. The challenge we have, we're still working on this, is trying to identify antibiotic prescriptions that aren't associated with an encounter. And unfortunately, in our system within Cerner, we can't unlink that. They have to choose an encounter to prescribe an antibiotic. And so we haven't been able to look at, did we see an increase in antibiotic prescribing from family medicine and internal medicine that is not associated with an encounter? And that's something we want to do. When we talk to family medicine and internal medicine, because we have had these conversations with them once we started to see this significant improvement, it was really a really significant education component to say, hey, this is what's happening. We need you aligned. And we haven't been able to fully get into family medicine and internal medicine for logical reasons. In fact, they have so many other things on their plates to focus on. So we've done it to a superficial degree, but we haven't gotten into the details where we can definitively say we didn't see an increase. I can tell you we didn't see a 50% increase. So I think if we did, it went up mildly. Yeah.
With this regional improvement in prescribing habits, did you see any regional changes in antibiotic or resistance?
Yeah, so too early to tell on that. So this is, really statewide, and we know that, particularly in the outpatient setting, to see improvements in drug resistance is going to take us years. Okay, it's definitely not something we can determine overnight. And what we'll probably see, well, what we will look for, who knows if we'll see it, is change in MRSA rates, because we know that antibiotic use drives MRSA colonization. And we'll also look at E. coli resistance, particularly to things like amoxicillin and fluoroquinolones. And so, yes, on the radar, but we haven't looked at it yet. We did look at C. diff, And C. diff is a rare complication of amoxicillin, which is the primary antibiotic that we use in urgent care. And so we haven't seen a signal yet there. We'll keep looking for it, though. One of you two.
You already asked one, Bryce. I'm an Instacare doc and just wondered, with making it, why did you include strep and community-acquired pneumonia when those except for maybe not strep, but have to have bacteria or antibiotics?
Great question. So thank you for your service at Instacare. So when we think about respiratory prescribing, we think of tier 1 diagnoses. Tier 1 diagnoses are conditions that should get an antibiotic. Okay, so things like you said, community-acquired pneumonia, group A strep, paratonsillar abscess, and there's a host of other ones. When we looked into that, there's 2 reasons we did it. One was variability in the way people use community-acquired pneumonia diagnosis. We saw plenty of CAP patients that had normal x-rays, okay, and so we wanted to make sure that we were just getting all of these. The other issues with group A strep testing in the fact that if somebody comes in, gets swabbed, it's group A strep, they get coded as group A strep. If they come in, get swabbed, and they don't have group A strep, they often get coded as pharyngitis, okay, which is a different ICD-10 code in tier 2 categories. And so we wanted to get out of that, likelihood of having testing available, likelihood of using testing, and then this idea of, which people have brought up, but hasn't really been shown in data, code shifting. Because what we hear from some concerned people when they look in the data, they say, oh, if you only focus on pharyngitis, you're just going to move people to use codes that antibiotics should be associated with, group A strep, for example. And so it was just a method for us to say, we're just going to take all comers, and our target's never going to be 0, right? Because you're going to get group A strep, you're going to get community-acquired pneumonia. And so that was the reason behind the why. And then we can go in and look at the specific codes. We didn't see any evidence of code shifting or anything like that. And I think partially is because we were using a metric that didn't really have any effect on code shifting. Hopefully that answers.
My second question is if you could give guidance on the best practice for the delayed prescription. Do you send it at the time you're at the visit? Do you really want to have them call in because that's just a headache? Or what if you're at a conference for the weekend?
Yeah.
Or do you print it and give it to them?
So really good question. So we like to make the distinction between a delayed prescription, which is, hey, I'm going to give you a script and you can fill it at your leisure, versus watchful waiting. Okay, so watchful waiting is somebody comes into a primary care clinic, said, oh, I've got these symptoms. The clinician says, okay, go home, symptomatic therapies. You call me if something changes. Okay, so I'm going to have you wait, and we're just going to watch this carefully. And if something changes, you don't need to come see me, but you need to call me back. Okay, that's watchful waiting. Versus a delayed script, they come in, they have those symptoms, and they leave with a script in hand. So watchful waiting works pretty well in folks that have a medical home, have it set up where people can call in and they can get recommendations. So primary care clinics can do that. Urgent care clinics can't do that. Right? It's a different doc, it's a different APP, they don't want to have to dig in. So we think that watchful waiting definitely is more of a primary care focus, whereas a delayed script is an urgent care focus. We elected to give them a paper script. Okay, so our recommendation was if you're going to do a delayed prescription, is that you use the delayed prescription order sentence, and instead of sending it to a pharmacy, you print it out. Okay, and then you give it to them. And so that's just another barrier that they have to say, okay, I have to go physically take this script in to Smith's or whatever it might be to get it filled. As opposed to saying, I'm just going to send it in. The pharmacy may fill that, right? They may not read that it's a delayed prescription, so they may just go ahead and fill it, and that's wasted time on their part, and they may never come get it. So we elected to say, print it out, hand it to them, let them go in. And there really was no stopping them. They could have gotten a delayed prescription and walked right over to the pharmacy and filled it. It all depended on the pharmacy, whether or not they actually abided by that delayed prescription. So the question is, can you post-date a delayed prescription? Yes, absolutely you can. I can tell you that a lot of the pharmacies don't even look at it. So, and the only script that by law you cannot fill based on the date is a narcotic. And so that's actually legislation that's going through that may change in terms of antibiotics prescribing. But even a post-dated script, because we've explored some of this, people can still go get it filled. And so it is one of the challenges we have with some of our community pharmacies.
Can you comment on coughs and pertussis? With strep throat, having a rapid strep test is very helpful to triage who you need to treat, but rapid point-of-care pertussis testing would be very helpful because if you could catch that early, it seems like there's more of a difference you could make rather than making that diagnosis late when you really can't make a difference.
Completely, and the public health implications too. I would say if you catch it early, people can obviously wear masks and avoid people and avoid spread. Man, that'd be really great if we had a point-of-care pertussis test. So a natural experiment that occurred recently to make the point-of-care testing was what happened with COVID. And so when COVID hit, we were worried about doing group A strep swabs because of, is this an aerosol generating procedure? So all of urgent care stopped doing group A strep swabs. Okay? And our antibiotic prescribing for that combination of group A strep and pharyngitis went from about 20% to 45%. Okay, we over doubled our antibiotic prescribing rate for pharyngitis when we stopped doing group A strep swabs. And when we reinstated it, it came right back down to what it was. Okay, so the reason I bring that up is just shows the natural experiment of using point-of-care testing and how valuable it can be. So I completely agree with you. The challenge is going to be having a platform in your clinic that is able to do a point-of-care test pertussis. I don't think it's on the Cepheid platform, which is what we use for flu and RSV, now COVID. And so it really would be, what is that cost-benefit analysis to be able to bring that in and maintain a system in your clinic? And for pertussis, that can be challenging. But yes, would be very, very useful. Just like it'd be very useful to have gonorrhea and chlamydia and HIV point-of-care testing in our clinics as well.
Do you have a suggestion or perhaps data that indicates that significant complications were avoided by your snarky comment about azithromycin?
Thank you for calling me out. It was a snarky comment. I completely agree. The data that we have on avoiding complication isn't just azithromycin. We're a low azithromycin prescribing state. At baseline, we were 9 to 10%. When you look at other states for respiratory encounters, that's many times 40 to 50% of respiratory encounters that get azithromycin. So at baseline, Utah in general does very well from an antibiotic prescribing standpoint, and even better from an azithromycin usage standpoint. So then we reduce it from 9% to 3% for respiratory encounters. We don't have, so those complications you're talking about, so things you think about is untreated sinusitis leading to brain abscess. You think about perforations and the like, perforations of eardrums. Those are rare events. And so when we look at them from an ICD-10 standpoint, you don't see any signal. And quite frankly, when you look at these from a national standpoint, the EU has done some of this because they have national data on these things that shows no signal when you decrease these antibiotics in terms of complications from severe complications from sinusitis. So the answer is we haven't looked specifically at azithro, but we have looked specifically at those constellation of symptoms and syndromes when we look at all antibiotic prescribing. We don't see any signal of worsening complications. Yep.
What was your main test that changed the behavior? Was it the white count or the temperature or the cultures or what was it, x-rays?
Yeah, so it's a question that we're trying to kind of unravel as, what changed? Like, what was it that really impacted? When you look at the prescribing, tier 3 came down, sinusitis prescribing came down a bit. So I think, and we did a lot of education. We did a lot of education around sinusitis and showing them the data that is relatively recent now, showing that the vast majority of sinusitis doesn't need an antibiotic. So most of these things, right, sinusitis and otitis and bronchitis, you don't have any diagnostics. Very few people that showed up to urgent care got a white count. None of them got CRPs. We don't have procalcitonin in the urgent care. If there was a concern for pneumonia, then they'd get a chest x-ray, but that's a relatively minor group. And so I would probably actually reflect to our urgent care clinician in the audience to kind of pontificate about what was it that changed. In my mind, we spent a lot of time on education, and we tied it to a quality indicator, and we were present and we showed up for the clinicians. So I don't have a definitive answer for you. I think it was all of the above in terms of why we improved.
The next thing I'd like you to tackle is the excess use of CT scans in the ER.
Yeah, well, I mean, I think
everything.
I think it brings up the idea of stewarding healthcare resources, whether it be radiologic stewardship or lab stewardship is something we're tackling now. And so laboratory stewardship in terms of the inappropriate use of respiratory film array panels. 14, 15 target respiratory film array panels that cost $400 to $500 a panel that aren't reimbursed by CMS. So I think you could say, well, what about diagnostic stewardship? What about lab stewardship? So yes, the answer is yes, and you can also add on any number of things to that. Yep.
I know that in your, when you interviewed patients before they came to the urgent care visits, you said 12 out of 13, I think, weren't expecting an antibiotic. It kind of goes against the JAMA Internal Medicine article in 2018 that suggested the #1 factor for patient satisfaction in an urgent care setting was if they got an antibiotic or not. I guess, and clearly you guys have done a good job of changing the culture with your patients, which is excellent. Coming from a really small healthcare setting with very poor resources, I guess, as far as bang for your buck, you guys did a lot of things. You guys put up posters, you guys, plastered the walls, and and you're with these really nice. Visually, pretty things to look at. But coming from a setting where we don't have necessarily the resources, bang for your buck. For us to implement and decrease our antibiotic, prescribing, what would you suggest is the biggest bang for our buck to make implementations?
Completely agree. So we've thought a bunch about this because you're right, this isn't transferable, right? We had this huge media budget, we were able to do all these incredible things with it. So, if you're in a family medicine, internal medicine clinic environment where you have relationships with patients, don't think this is going to change overnight. I'm sure you have patients that say, every time I get this drug, right? I would say start having those conversations and have those conversations every time and start small, right? And then eventually you're going to say, hey, you know what? This time let's try symptomatic therapies first, and then you call me back if your symptoms worsen, okay? And we can give you the website. All of the patient education materials, all of our algorithms, all of the posters are available on intermountainhealthcare.org. So you can download and use them at will, change the font, change the labels, go for it. And so all those are available. And so I'd say start the conversation and start using things like symptomatic therapies checklists and also the watchful waiting tool. And then start changing that culture of your clinic, okay? And I'd say that's where I would start, is having those conversations with patients. And, we know that you're not going to change everybody. You thought my azithromycin alert was obnoxious. That's where I'd start. And, try to start changing the culture. And I would, if you have partners in your clinic, I would talk with them as well. And, easy things that have shown to have a 10% reduction is putting a poster in your clinic that says, I'm committed to improving antibiotic prescribing. 10% reduction just with that. So there are some really kind of low-cost interventions that you could use. And I would start there by changing the culture. Okay, Petronella. You're welcome.